know what you're thinking. This is going to be a total waste of time. Cultural competency training is just another thing that you're going to have to fit into your already overbooked schedule, and you doubt if there's any payoff in terms of clinical outcomes. Wrong.
You don't really know a person by the pigment of their face. It's sad, tragic. I misunderstood, remain ignored.
The reason this is really important is because so many African Americans die.
Many physicians, social scientists, and others argue that incorporating aspects of a patient's existing value and belief system into treatment discussions leads to more patient satisfaction, better compliance, and improved outcomes. To achieve this, physicians need to step back from their worldview and understand how their patients view things.
So let's think about something else that you think either causes cancer or helps it spread.
Excessive drinking can cause cancer.
Right.
To gain the perspective of how some low-income African Americans view cancer, we conducted over 40 focus groups with African American residents of Cleveland's public housing estates. During these sessions, some common themes emerged. They include mistrust of the medical system, ethno-medical beliefs and fears, daily life issues, and spirituality. For the next few minutes, we're going to present views that members of our target population share about these topics. In each section, we will present a common problem that may arise and a solution you can apply during clinical encounters. We begin with mistrust. Many African Americans distrust the medical system as injurious and exploitative of poor people in general and of blacks in particular.
I don't care how you look at it. Every one of us is different, but we're not prostitutes. This is the attitude that we are treated with. If you're not a prostitute, you're a criminal.
Disrespect, true. Racial, absolutely. Financial, definitely. They all go together. You know, and I strongly believe that plays a major part in how much medical attention I get.
I know if I go to a hospital at any given time, I would like to have the thought that I would be treated the same way as any other person coming in, you know. But you can't help but have a feeling that economics have a big part in this.
And what gives you that feeling? What gives you the feeling?
For one thing is, I know that certain medications that would deal with whatever ailment I may have, they would look at my insurance rating, and that would determine whether I got generic placebos, or if I got the top flight drug to deal with that problem.
Knowing out the gate that some patients may be suspicious of generic drugs, physicians need to be prepared to explain that most generic drugs contain the same ingredients as top flight ones. They are cheaper because the patent has run out, not because doctors are trying to give poor patients lesser medicine. Many focus group members also think doctors want to operate on people and recommend expensive treatments just to make money.
I'll say what I really want the doctor to know is, if you really just in it for the money, get out.
There you go.
Okay, all right, let's go to...
You need to have some empathy and some sympathy, because it might happen to you.
All doctors aren't in it for the money. Some have your best interests at heart. But the majority of them, this is just my opinion, my belief, is that they're at the money. You know what I'm saying? It's big business.
Many black patients come into medical encounters with suspicion and mistrust, fueled by theory and rumor, as well as real-life experiences.
I have a relative that was in that Tuskegee experiment. And really, we don't trust the medical profession on certain things. I ain't trying, it ain't funny, I'm just being honest with you. I mean, because that was a clinical study.
It's also important to realize that because of real experiences with racism and/or perceived racism, some members of the black population tend to perceive things as discriminatory that doctors may not even recognize or ever intend. For example, many focus group participants think that when a doctor says he's going to run some additional tests, he's really doing an experiment on them.
When you say diagnostic test, they think that what you're saying is you're going to do an experiment. You're going to run an experiment on them or on the results of the extraction of fluids or whatever, cells, cell cultures, and so forth.
The problem: because of an overriding shadow of mistrust and suspicion, common things that doctors do and say may be misinterpreted by some African American patients.
Hi, Linda, how are you today?
The solution? Go the extra mile to explain everything you are going to do in detail, but do it in a way that does not make patients feel you're talking down to them. Instead, put the blame on yourself. Here's an effective phrase: I may not always be as clear as I should be, so please help me understand the best way to explain things to you. We now move on to ethno-medical beliefs and fears.
Cancer is ugly. It's a disease that, from my experience and the people that I've been really, really close to that have had it, have not survived.
Many low-income African Americans do not understand the fact that African American patients tend to present later in their stage of diagnosis and therefore fare worse. Often, what their experiences and their realities tell them is that when someone with cancer goes to the doctor, they die.
Once they go to the doctor, that's it.
So you're saying the treatment
Kills them. The treatment kills them.
Every time I hear conversation, it's always, well, once they had surgery, once the doctor opened them up, people say, that's it.
Many African Americans believe cancer is a form of rotting or an infection that eats on you. Many believe all cancers are alike, and they are classified with other conditions that eat on you or cause wasting, such as AIDS. Food additives, injuries like bruising or other kinds of trauma to a body part, sexual behaviors, germs and things in the air, microwave ovens, biomedical treatments and diagnostic procedures like x-rays or mammograms are all thought to be among the causes of cancer. Many people think cancer just spreads to the next thing in its way. Many do not understand the concept of systemic disease spread through the blood or lymphatic systems.
Don't make no sense. Then how is it spread?
They don't make no sense.
You know, if you got cancer in the thigh, how you get cancer way up here? You know what I'm saying?
Many African Americans think that if something is not bothering you, you should not mess with it. They also think the stress and worry associated with cancer will kill you faster than the disease.
You know what I'm saying? It'll break them down even more. So maybe they should find a better way, or, some type of psychological, where they can speak with these people and maybe not have them so far thinking that they're just.
You need that psychological and emotional support
right
there.
Right then and there from the beginning.
Besides believing cancer is a death sentence, many African Americans believe the myth: when air hits cancer during an operation, it causes the cancer to spread.
Once they begin to operate, it spread it throughout our whole body.
And you connect the spread to the operation?
To the operation, yeah.
We've been told in the black community, don't let them cut you if they say you got cancer, because once the air hit it, it spreads.
Myths about surgery make sense to many African Americans because they conceptualize cancer like the contents of an unopened can of food. It's fine as long as you leave it alone. As soon as you open it up, germs in the air make it spoil and rot.
Anytime you open up something, you're exposing it.
Okay.
And
exposing it to
the air.
To the air.
To the air.
And what about the air?
It sprays. It makes them cells or whatever move around.
How does the air make it do that? Trying to get to the real, how does this work? Germs.
Many people think cancer comes from chemicals and other unnatural substances in our processed world. To them, chemotherapy means chemicals. It seems illogical to treat cancers with the very substances that cause them. Some African Americans are afraid that chemicals or poisons in chemotherapy drugs are so strong that they will turn their skin darker.
Doctors need to know that that skin color is very deep rooted in the black neighborhood. Skin color is important. And if you're brown, you can stick around. If you're black, you got to get back. That mentality still exists.
Radiation is also very feared.
We are scared to death of radiation. Because now, if it didn't have cancer, I know you're going to make sure I got it now.
That radiation ain't no joke. Sure isn't. Because I had to stay in one spot. I couldn't move. They put you down where you can't move to take you move. You know that thing might go somewhere else, burn you up.
The problem, surgery, chemotherapy, and radiation do not make sense to many African Americans because these treatments usually are not explained in ways that take into account ethnomedical beliefs, understandings, and fears. The solution? Ask about a patient's fears and concerns. Also acknowledge their beliefs and try to incorporate harmless aspects of them into treatment discussions.
It's important to understand where the patient is, not where the patient should be, where the patient is, and then to begin the conversation there.
Asking a patient a few simple questions adopted from an explanatory model of medicine from Arthur Kleinman of Harvard can help you determine where your patient is in their understanding of cancer. Here's an example of a culturally sensitive treatment discussion. Mr. Green is a 67-year-old African-American male with an advanced stage squamous cell carcinoma of the tonsil with neck metastasis. Recommendation is for combined modality treatment using radiation and chemotherapy. The surgeon explains the goal is to try and cure the primary tumor with the chemoradiation and then do a planned neck dissection. The surgeon begins the treatment discussion with a brief introduction of cancer and the available treatments. He goes on to explain how using chemotherapy in combination with radiation is a way to get the maximum benefit from radiation and to try to kill cancer cells that may have escaped from the tumor and traveled other places. The doctor then engages in some short dialogue to help create buy-in. He says,
"Now that I've told you about the different kinds of treatment, it would help me to know a little bit about your thoughts. What do you think caused your cancer?"
The patient responds,
"I kept biting my tongue, then it started getting sore in that spot, and then it balled up into a knot."
The physician respectfully nods and says,
"That's an interesting thought. Here's what we found in medicine. Cancer is the result of changes in individual cells that cause the cells to grow on top of each other and grow out of control, kind of like the knot or swelling you brought up. The cells can also travel throughout the body and spread like seeds in the wind. That's where radiation and chemotherapy come into the picture. Radiation and chemo are two treatments we use to kill cancer cells. I'm sure you have heard scary things about chemo and radiation. Do you have any special concerns you want me to address?"
I always thought that radiation killed people and burned their skin, and when they dropped the atom bomb, it burned the people all up. And I just want to know, this is the same kind of stuff y'all gonna put on my body?
The doctor listens to the patient's fears about radiation and nuclear bombs. He goes on to explain the radiation used in medicine is used with very precise measurements that are calculated on a computer and allow doctors to know exactly how to hit the cancer cells while minimizing damage to the surrounding tissue. The doctor lets the patient know that while his skin may get dry or irritated, the radiation machine is not going to seriously burn him. Asking about specific fears, using reflective listening, and incorporating aspects of the patient's beliefs about cancer into treatment discussions helps the patient feel he's been listened to, understood, and most importantly, respected.
Really listening to them and respecting what they say, not necessarily agreeing with everything they say by any means, but respecting what they say, you make them feel like a person, okay? And that empowers them to act.
Our next topic is daily life issues. In negotiating a treatment plan, doctors also need to consider African American patients' daily living issues and responsibilities. For example, child care issues may affect women of all ages. Many grandmothers and great-grandmothers are raising their children's children. Our focus groups say daily life issues can sometimes be a barrier to participating in clinical trials. For example, some patients may not have money to pay for parking at the hospital, In fact, some people may not even have a car.
No transportation, so they need to specifically say, well, if you don't have transportation, we will be able to,
give you transportation and provide it.
Provide transportation backwards and forwards to this facility.
We live, well, I'm not saying we as everyone, but, I have a lot of issues living in the inner city. And I'm not saying that just because being black or part of a minority. You have so many of these other obstacles. Oh, shit, I'm going to get killed before I, take this. I get hit or robbed or something like that.
The problem? Patients may have issues and concerns you never dreamed of. The solution? Probe for hidden issues that may affect a patient's ability to comply with treatment or participate in a clinical trial. When necessary, offer the support of a social worker. We close with spiritual beliefs. Many of our respondents say only God can cure disease, and that having faith and learning to accept God's will are more important than biomedical treatments. Doctors may view this negatively as fatalism, but to many African Americans, such strong faith is a worthy, positive goal. They may view getting cancer as God's plan for them to go home. The problem? It may be difficult to convince some patients to undergo treatment if they think the only thing that matters is God's will. The solution? Adopt an approach that allows a patient to hold on to their religious beliefs, but also endorses the advancements of medical science. Here's some dialogue that may help you successfully engage a patient who has strong faith. I meet many patients who believe God gives doctors the knowledge to help others. Maybe our meeting and my ability to provide you with treatment is part of God's plan. You may squirm at the idea of bringing up personal issues like faith and prayer in a traditional medical interview, but many of our focus group members say it's important.
My faith is powerful. Faith in God is powerful. A lot of people take and shuck that to the side, but your faith is powerful. And then the fact that the doctors have went through medical school, God helped them do that. God gave them the knowledge to do that. So if you put the two together, it becomes like a power ball.
Hi, Dr. Leviton.
Here's an example of how to integrate faith into a treatment discussion.
We've talked about your cancer and about your radiation and your chemotherapy, and I've asked you about a lot of things about your history and your family, but I've never really asked you what your sources of strength and support are, whether that's family, whether that's your faith.
First is God, my family, my church family, and friends.
I hope this isn't too personal a question, but can you tell me a little bit more about what your faith really is about and what that consists of?
I've always been involved in the church, worked in the church, and have a strong belief in God.
Given your faith, and you've told me a little bit about that, and my role as one of your doctors, how do you see us working together, and how do you see my own strengths and weaknesses as your physician fitting in with your faith?
I see God working through you. I asked Him to guide you in the directions that you should go to heal me.
We close with a review of sample language you can use to broach the subject of faith with patients. What are your sources of strength? Do you tend to rely on family, friends, or maybe prayer? If the response refers to religion, prayer, faith, or other spiritual issues, proceed with some of the following. Can you tell me a little bit about your faith? Do you go to a special church, mosque, or are you part of a particular group? Is there a pastor or special person that you connect with spiritually? Given your faith, and my role as one of your doctors, how do you see us working together? There is power in all your patients' beliefs. Cultural competence means building upon aspects of those beliefs to create mutual respect and a feeling of empowerment.
Give the person, especially the disadvantaged person, a voice, and that helps to make them feel like a person.
Treat us as people first and patient last. Patient is so institutionalized, a patient. People is individual thing. So doctors can be an agency of change before they even open up their medicine bag.